Hello and good evening, everyone. Welcome to today's webinar. I hope everyone can hear me well. My name is Dr. Kimmo Mäkinen, and I'm the co-founder of Medicines for Africa. I want to welcome you all to today's webinar, which forms part of the Medicines for Africa progressive learning series called Building Frontline Defense Against Unsafe Medicines. It's a 12-part series focused on strengthening medicine safety and patient safety systems across the African continent. Today is webinar number 4. This series is designed to strengthen frontline capacity to reduce preventable harm, improve medicine safety, and support stronger healthcare systems through greater awareness, vigilance, leadership, and practical action. At its core, this program is about the people who interact with patients and medicines every day. Healthcare workers, pharmacists, inspectors, regulators, and other frontline professionals, because those frontline interactions are often the first opportunity to detect risk, prevent harm, and protect lives. Across this series, we explore not only the risks associated with unsafe and poor quality medicines, but also the broader systems, behaviors, leadership practices, and safety cultures that influence patient outcomes across healthcare environments. This program examines how unsafe, substandard, and falsified medicines are recognized and addressed in practice, while also exploring the systems, behaviors, and frontline decision-making processes that support safer patient care. Today's session focuses specifically on recognizing and responding to medication-related harm in African health systems. Unsafe medicines and medication-related harm remain among the most significant, yet most preventable causes of patient harm across healthcare environments. This webinar places the spotlight on the everyday realities faced by doctors, pharmacists, nurses, and other healthcare professionals during prescribing, dispensing, and medicine administration. Because every interaction with the medicine carries two possibilities: an opportunity to protect the patient or a potential point of harm. This session explores how healthcare professionals can better recognize, interpret, and respond to medication-related risks in real-world clinical settings. Importantly, as we will hear from our speaker tonight, patient and medication safety are not only clinical responsibilities, they are deeply influenced by organizational culture, leadership, communication, teamwork, and system design. Tonight, we'll look at a cross-country case study examining work across hospitals in Ghana, Ethiopia, and South Africa, focused on strengthening safety culture, measuring harm, and building patient safety capacity across multiple levels of the health system. At the heart of today's webinar is one important message. Safe healthcare systems are built not only through policies and procedures, but through cultures where people feel empowered to speak up, learn from mistakes, and work together to protect patients. And now, it's my pleasure to introduce our speaker for today, Dr. Tsotsi Tete, Chief Executive Officer of the National Vaccine Institute in Ghana. Dr. Tsotsi Tete is a highly respected public health physician and global health leader with extensive experience in health system strengthening, quality improvement, and institutional leadership across Africa and the Middle East. He currently serves as the CEO of the National Vaccine Institute in Ghana, a role to which he was appointed by the President of Ghana, His Excellency John Dramani Mahama, reflecting his long-standing contributions to national and regional health system development. Previously, Dr. Tsotsi Tete led Ghana's nationally recognized Project 5's Alive initiative, which is a large-scale quality improvement program implemented across hospitals and sub-districts nationwide that contributed to significant reductions in facility-based child mortality. Over the years, Dr. Sotsi Tete has also supported health system reform and rebuilding efforts in countries including Ethiopia and Liberia, with a strong focus on improving care quality and strengthening patient safety systems. Today, Dr. Sotsi Tete brings a wealth of practical experience, leadership insight, and regional expertise to our discussion on recognizing and responding to medication-related harm in African health systems. So, Dr. Sotsi Tete, welcome to this webinar. The floor is yours.
Thank you, Dr. McKinnon, for having me. And then thank you also, Lenias Wenda, for inviting me to speak at this auspicious webinar series that you've put together. I think all of us involved in the quality and safety discussions in the region or working as frontline health professionals will testify to the fact that this is a real area of need. I have my own horror stories from some errors that I myself as a district medical practitioner got involved in my work. And so when I have the opportunity to lead IHI's work in Africa, and there was some amount of funding to support this work, I grabbed it with both hands because it was just an opportunity to make a difference. So it's an important area that you're working in, and the statistics from WHO would even speak to the fact that errors and harm, particularly the areas of avoidable harm, are things that are everyday occurrences that we can do things about. Next slide, please. So as you've indicated in your introduction, if we can move ahead, this is an opportunity to speak to an initiative that we worked on in 3 African countries, which we christened the Africa Hospitals Patient Safety Initiative, that is the APSI. So I'll talk a little bit about its design, some of the key approaches that we use and the interventions that we promoted. And then I would end by focusing a little bit on the culture, which often is very foundational to these things. It's not just about whatever it is that you're doing, new medications and all of new technology, yes, but the more foundational issues are worth looking at. And I thought I would start with a story of a friend and a brother called Clement on the next slide. Now, Clement was invited to the design meeting of the APSI initiative, and his story served as a galvanizing moment for all of us working in this area. And like many of us, he was a young professional. He still is an architect who had gone around the country to address certain issues and was involved in a road traffic accident, a very horrific one, in which the driver in his vehicle lost his life. So he ended up with multiple injuries, abdominal injuries, had to have, I think, about 5 or so surgeries, currently walks with a limp. So it was really life-changing, a very serious one. And he was recounting his experience in a teaching hospital in Accra. And one thing that he said as part of his concluding statement stuck with me throughout. And what he said was that I had to force myself to be discharged from the hospital. And if I hadn't done that, I'm sure you people would have killed me sooner than the condition itself. So at the earliest opportunity, he asked to be discharged. So it was a series of errors. It was a series of bad communications. It was a series of people not listening to him when he thought that there was something going wrong. And there was one particular episode that stuck with me because it related to medication. And he was woken up by a nurse around 5 a.m. to take his medications. And he said that I don't often take medications at 5 a.m. I know the times that I take, so this is not a good time for it. And there was this back and forth, why you been stubborn? Why don't you just take the medication and all of that? But he refused to take it. And so the nurse walked back angrily. In about a couple of hours, a senior nurse and that nurse also came back to apologize to him because it was the wrong medication being given to the wrong patient. He was not the one, and he was absolutely correct to refuse the medication. This then reflects a number of issues that go on, as I said, on a daily basis in any of our hospitals. If we can move forward. Thank you very much. So this little work that we did was really based on WHO's third global safety challenge. And this is where they were talking about medication without harm, an announcement that was made much earlier. And often, as you know, when you make these global declarations and there's no intentional effort to roll it down at the level of care delivery, you don't make much of a difference. It's not as easy as designing protocols and tools and expecting that automatically people will be able to apply it in a reliable manner in a way that actually reduces harm. So this is really the challenge that we decided to take. And when I say we, I'm talking about the Institute for Healthcare Improvement, my former organization, Ubora Quality Institute, which is a healthcare quality and safety institute based in Ghana, the Ministry of Health of Ghana, of course, and then the World Health Organization, both globally and in country. So we came together and asked ourselves a critical question of what it would mean to pursue a project on medication without harm in Africa. Next slide, please. Yeah, so we convened an expert meeting in Accra, brought in expert faculty from all over, especially the four organizations that I've spoken about, including patients, because the voice of patients was critical. And then we began to unpack when we say medication without harm, which are the focus areas, what are the priority interventions to promote, and how can we generally make care safer than we think it is, especially as it relates to medications. Next slide, please. So I've indicated that this was an initiative targeting 3 African countries, Ghana, Ethiopia, and then South Africa. And we selected 3 to 4 hospitals in each country and ended up with about 10 hospitals. In terms of the data, I just focused a little bit on the data that I got from Ghana. But these were the 10 hospitals that we worked in, and realized that we are at different levels of maturity working on different things. Next slide, please. And there were 4 key areas that after the design meeting, we called out. The first one had to do with improvement in safety culture. We realized that if things were to improve, then 4 areas needed to be tackled in terms of the culture, issues regarding leadership, standards and protocols around service delivery, the capacity of the health professionals delivering the service, and then also the measurement systems. When you want to reduce harm, the question is, do you even have a way of measuring the harm being caused by these medications to be able to tell whether harm is being caused or not? The second big block had to do with capacity building. A lot of times people want to do things, but they don't realize that some of these things include specific skill sets that people need to have before they can intervene in the areas that they are keen to intervene in. So one needs to be deliberate in teaching and training people and building skills, whether it is an improvement science in general or specific to medication safety. There is a need to be intentional about building the capacity. And then 3, a number of strategies around harm reduction, including using peer-to-peer learning approaches of how these 10 hospitals could learn from each other. And 4thly, dissemination of the key lessons at multiple levels. And I assume that you've given me an opportunity to disseminate some of the lessons from here as well. Next slide, please. So this were the tenets, and we use this well-known framework. Some of you may know it's called the Collaborative Learning Network, where the hospitals came together. There were opportunities to meet in person and virtually as well, where we taught various tools that they could use to get into the root causes of the issues driving the medication-related harm. And then they would report out their own data, and we would sort of interrogate it. And in between, there'll be a time for in-person visits or virtual calls to find out what difficulties they were facing. They will be taught the PDSA cycles, plan, do, study out cycles, so they could actually make changes. It's not just about measurement, but it's about effecting changes in your facilities. And then also, if there were systemic roadblocks, how we could connect with their managers at the district and national levels to unravel these roadblocks. So this was the general design, that we came up with to guide this work. Next slide, please. So specific to Ghana, there were these hospitals. And again, remember that I'm here to share not so much the specifics about this hospital did that, that hospital did that, more about the principles and what we can learn from them. So if you see the selection of hospitals, and this is something that we did at multiple levels, you would find that we had public hospitals, we had faith-based hospitals, we had private, purely private hospitals. You know, we had hospitals that were very urbanized and hospitals that were rural. The idea was that at the end of the day, you wanted the learning to be rich. You wanted the hospitals that were at different levels of sophistication to bring their own experiences to the table so that would accelerate the learning, the change management process, and whatever improvements that one seeks to achieve. Next slide, please. So we were talking about reducing medication-related harm. What specifically were we talking about? One was transitions of care. So as people move from the home to the emergency, from the ER to the wards, from the wards to the surgical theaters, anytime people move from one place to the other, there's a great opportunity for errors and for harm. So that was something that we had to look at. People forget what medications they were taking. Health workers don't ask enough about what medications you're already on. They prescribe new ones. They repeat old ones. Before you're aware, people are taking Panadol, they're taking paracetamol, they're taking the same medication is being given in 3 different ways because nobody was careful enough to examine what they are doing at various points. The second one had to do with high alert medications. So the ones that in many instances either work on the CNS or go straight into the blood and can cause an immediate reaction. So whether it's insulin, whether it's narcotics, and all of that. So the medications that you're using that you think have a high propensity to cause harm, we thought that those high alert medications needed to be focused on. Then polypharmacy, as some would say, appropriate polypharmacy. But then if we know what the standard treatment guidelines will say about managing, let's say, malaria or hypertension or, whatever, and you have, let's say, 2 to 3 drugs that are appropriate for the management of this condition, unless you're dealing with some comorbidities and so on and so forth. So if you did your medication reconciliation, yes, you would help to manage transitions, but you would also know a patient who is taking 6 medications when actually all they need will be 2 or 3. So these were the areas that we thought needed the most attention. And everything was anchored on leadership and culture. Then we came up with the next slide, which is going into the driver diagram, which is your theory, really, of what is driving these. And I think I've said a little bit about that. In terms of polypharmacy, we looked at it at the level of the health providers, at the level of the patients, and then also at the level of the health system. Are these things covered in the treatment guidelines? Is that why people will be given more than they are given, or do they have clarity from the protocols that are being used? In terms of the patients, one needs to pay attention, for example, to the health-seeking behaviors. If you're working in a system like we have in Ghana, where people are likely to self-medicate or to try some options and see the health facilities as the last resort, then they are likely to have come in already consuming all kinds of things. And if you do not take a detailed history, you would add on to it, and they may not tell you and continue to take what they've already started in addition to what you're giving to them. Similarly, for the transitions of care, I've mentioned it. People go and start medications on new wards without checking what they are already on, and there is no awareness that you can actually do medication reconciliation and weed out those that don't need to be taken at each point in time. So you find out that as people go, they slip, or one doctor says that, "Oh, but I thought you had medications already. I didn't realize you had run out." Or patient says that, "I didn't realize that in going for the surgery, I needed to stop taking this medication." And all of those things just add on to things and lead to errors and then harm. And then, of course, the polypharmacy issues, where sometimes even the patients themselves at their level think the more the medications, the better. And the health professionals also don't realize that, they are, you don't have to give so many medications, and there are clear guidelines. For example, if you were to start a patient on antihypertensives, there's guidance as to when you're going to, if you think it's not effective, whether when you're going to increase the dose, and when you think you might want to add a second drug or not. And sometimes not being intentional about these things means that we just pump them with drugs. Also, the issue about not making diagnosis and treating symptomatically. So patient says, I have headache, I have this, I have that, and you begin to treat. You treat cough, you treat sneezing, you treat loss of appetite, you treat fever, you treat rigors. But perhaps if you were more careful about making a primary diagnosis, then the treatment is more straightforward as opposed to treating the symptoms. So there were layers at the level of the patient, layers at the level of the health professionals, and health system type issues that we had to grapple with. Next slide. We'll then go on into some of the measurement strategies. So we started looking at adverse drug events. And in terms of the high alert medications, because you couldn't do it for everything, you had narcotics, anticoagulants, insulin, sedatives, and all of these things. And then where were we experiencing adverse drug, reactions with respect to these medications? Because these then were the high alert medications that we were looking at. And then we would measure the percentage. It wasn't really easy to come up with this measurement approach because South Africa, I believe, had a very robust incident reporting system, from national right down to the lowest levels. Ghana didn't. So a lot of this felt like it was new, that we were new measures, new indicators that we were defining. And that meant that we had to be very careful about even the data platforms that will be used to collect this. And a lot of it then became paper-based forms that data officers were now collecting. And the idea was that once we completed the exercise, we could then make some advocacy to the health service to incorporate it into the district health information management system and to make it routinely reported. Because it's very difficult when you say you want to reduce harm, but you cannot tell what harm is being caused and how specifically you're going to do that. Then we also look at percentage of patients with medication reconciliation being performed. Again, we train health professionals and then encourage them to sample folders, and within those folders, find out the number of medications that had been prescribed, looked at what they had now on them and what had been prescribed in education, and reconcile to be sure that they were taking absolutely what they needed to take. And sometimes you'd be surprised. The good thing about the med reconciliation was that in addition, it then helped you to see issues of polypharmacy. Then we've got registered professional nurses who were conducting failure modes on the high risk medications that I've mentioned, to be able to, at least through the processes of orders being placed, dispensing, administering these medications, what were the failure points? Was education being given? What type of education was given? Did you have maybe some leaflet to guide the information that you were given? Was there an opportunity for patients to ask questions to clarify? I have had instances as a district medical practitioner where I prescribed suppository diclofenac, and asked the patient to go and pick it up from the pharmacy and see me after a week. Patient comes back after a week, and I ask how she's doing, and she says the medicines, but it was very difficult to swallow. Swallow? Did you swallow the medicines? She said, yes, I swallowed the medicines. So now I'm horrified. So I'm calling the pharmacist, and pharmacist said, well, I explained to her. She said, no, you didn't explain to me, and it's becoming some sort of an argument. The bottom line is that the patient has been swallowing the suppositories for 1 week. So it's clear to me that I didn't do something right. When I prescribed, I didn't say it explicitly. When she went to the pharmacy also didn't say it explicitly. She was just handed over the medications. It was thought that, she would know how to administer these bullets. It's what they call it. And now we've messed it up, So looking at these failure modes and then being more intentional about the interaction with the patients really made the difference. Next slide, please. Then many of you know about the IHI Global Trigger Tool. that also attempts to measure the overall level of harm from medications. Again, this was new. This is not something that is routinely used to measure, but then we used it, trained the people. It involved a retrospective review of the patient records, and then to look at the triggers. So if you're looking at anticoagulants and you look for potential bleeding episodes, to identify possible adverse drug events. And then once you identify those, we would come back and try and correct the system going forward in terms of how we are administering these drugs, whether we are using the correct doses and all of that. Next slide, please. So this was piloted in Ethiopia and Ghana, and maybe not to our surprise, but we did see issues of harm, and also issues where we had seen the triggers. The adverse drug events had been recorded, but without harm. Of course, thankfully, those incidents without harm were more than those incidents recording harm. And also, the tool has all of these various categories of harm, where it can be reversed, or is irreversible, or at the very worst, it results in loss of life. So you then try to categorize them. And again, thankfully, in Ethiopia, out of the 3 incidents of harm, there was none that, was at a high grade. Even for Ghana as well, just 1, and then 6 in category A. So again, the point is that it's good for us to be systematic, because prior to this initiative, I wouldn't have been able to say that any harm really was actually happening. I would just say that, well, yes, it's possible. From your individual experience, you can say it. But at a system level, is there a way in which you can systematically collect the data and say that things can be improved one way or the other? And I think that was the opportunity that we had. Next slide, please. So then we realized that we were already going into measurement. We're going into making of changes. We were doing all kinds of things. But you realize that the system that you're working in is not primed to intervene in the way that you are thinking. You think it's a straightforward issue of training people to do medication reconciliation, or training people in Excel to measure tools and so on and so forth. And yet there may be more fundamental issues. Are leaders ready to confront the fact that actually there are instances where we are causing harm by the very setup of the system? And this is where we feel like that, yes, data and measurement systems are fundamental to safety. And so is culture. And actually culture then puts a greater burden on leaders as to what to do. Recently in Ghana, there's been an incident where a patient died because patient was being tossed from hospital to hospital after suffering a road traffic accident. And you may have heard of the famous no bed syndrome, because health professionals said there was no bed. Patient kept getting tossed until patient died. And a report has just been issued, and there's an uproar as to why the report is naming 3 doctors and calling them out for what they did not do right, and so on and so forth, because it's like you say no culture of blame and all of that. You don't want to name and shame and all of those things. So this definition here of culture is important, because whilst it talks about no blame, it also says that health professionals will need to be held accountable for unprofessional conduct, but they should not be punished for mistakes, and they should not be punished for errors. And when these errors are identified, they should be mitigated before harm occurs. And the systems are in place to support staff to learn from errors and near misses and to prevent recurrence. So that is the atmosphere that the leader wants to create. That is the culture that you want to build up. And hopefully, once you address those systemic issues, we will not end up in a situation where there is pure unprofessional conduct that people would be held accountable for. And so then subsequently we'll find out how leaders of organizations can set the tone for this. So then the question on the next slide was, so since this is a culture that we are trying to drive, is it even possible to measure this culture? And we found out, yes, actually on the next slide, there are ways in which we can measure this culture. So there are tools for measuring at the leadership and management level. And this by using the Leading a Culture of Safety tool, again, developed by IHI and I believe the Patient Safety Foundation. And then also tools for measuring culture at the level of clinical leadership on the wards and all of that, the Safety Attitude Questionnaire. So this is what we tried to deploy as a new tool to test it out. We adapted it, made the questions more relevant, and then we worked on it. So we'll see what the numbers also look like on the subsequent slide. So the Safety Attitude Questionnaire, which is focusing on the frontline delivery on the wards, the consulting rooms, and wherever else that we are delivering service, looked at these 5 areas, these 7 areas that are flashed up here, and maybe subsequently I'll be able to touch them one by one, but they will be scored 1 to 5. The higher the score, the better the safety attitudes within the facility. So the first that I will just speak to briefly, and I'll just highlight 1 or 2 of the questions that will be asked on the next slide, just to make the point. So let's say team satisfaction, where we realize how important it was to have a culture that people can speak up if they perceive a problem with a patient care. You know, be you a nurse or a pharmacist or an orderly or a young doctor, do we have a culture where you can speak up and highlight a particular area if you have disagreements, plus a number of the other questions. Next slide, please. Then we would also talk about the safety climate. Would you feel safe being treated in your facility as a patient? Do you feel that given the level of care that you see and you are part of, do you feel you will be safe? And in the kind of relations you have with your leaders, do you think that you receive appropriate feedback about your performance? Or is it so hostile that you're unable to discuss even errors and near misses? So you carry them home and everybody pretends that this is just perfect. So that is the safety climate that we are working in. Again, these are the sort of questions that we explored. The next one then also focuses on job satisfaction, with simple questions like whether you like your job, whether the teams in which you engage make you feel like there's a big family and it's a good place. You feel proud of your work and the way everybody shows up at work with very high morale. So that was under job satisfaction. The next one then talked about stress, where if you look at the workload that people are doing, it's overwhelming, and you know about human factors. It's not that I want to prescribe the wrong medication. It's not like I don't want to educate the patient. It's just that by design, the work is so overwhelming that I'm in a hurry to get through the patients. I recall that when I was a district medical practitioner, sometimes I would see over 100 patients at the outpatient department, and there is no concept of a closing time. You close when the patients are finished, so you know what will happen probably at the end of the shift. You are exhausted. And if we were truly to be measuring, you might see more errors at the end of the shift. So recognizing that stress and seeing how as managers we can intervene proactively. There was some work that I did in the early days of my quality improvement initiative when I was doing some training, and I tried to look at mortalities of newborns in a district hospital. And it was very dramatic that I saw an increased number of mortalities and delays in having cesarean sessions at the tail end of certain weekend shifts. As we investigated it, the issues were that the weekend shift started on a Thursday. So by Saturday, Sunday, people were exhausted. And then when they were called, they were dragging their feet and so on and so forth. And it didn't seem to work very, very effectively. And then, of course, people would then start disappearing here and there. And that also was problematic. So the stresses associated with the work, the fatigue, and how that impacts quality and safety, these are issues that we also need to pay attention to. The next slide. Perceptions of unit management. Yes, whether the managers are truly supporting your work and your efforts, or they just blame people and don't work on creating an atmosphere that supports them to do better, to do what they want to do. Whether management assumes that health workers are inherently good people who want to do a good job, or it is that they want to make a mistake, so they need to be blamed, you know. And when things go wrong, the first point is not that we want to blame them, but it's about what were the conditions prevailing that would make this error possible with this particular medication that was administered. When a patient is prescribed subcutaneous heparin and a nurse administered it intravenously, which is a real life incident, what made it possible? Is it that the nurse was a bad person, or is it that upon further engagement, you realize that as a district hospital nurse, she's never had the opportunity to administer subcutaneous heparin before over the last 10 years. New doctors have come in who are used to prescribing it, and they have prescribed it, but nobody has taken account of the fact that this is a new drug to them. And so a mistake has been made. Are you going to punish the nurse? Or are you going to say that, oh, we need to train, and we need to, when we want to introduce medications, we have to establish new protocols and prepare the grounds? So if the management is supportive, fine. But if not, then you worsen the problem around culture, because really the culture is to be driven by the leaders. And we shouldn't rush to blame frontline workers. Next slide. So these were the things, perceptions of hospital management. Next slide. I've spoken a little bit about this. Support for daily efforts, doing management, supporting them to do a good job, the working conditions, whether staffing the norms match the load of work, whether there are training opportunities to match the complexity, similar to the example that I cited. Next example, next slide. So these were the things that we measured. And you will see that almost in every one of the hospitals, there's a lot of joy in their teams, in their core teams. Like on the ward, they are happy with their management, they are happy with their staff, they think the climate is good and all of that. But then when it comes to perceptions of hospital management, they feel like hospital managers are not supporting them to be able, giving them the equipment that they need to be able to do a good job. There's a lot of stress, that is felt by the frontline workers. They don't think that they would even seek care in their own hospitals because they don't feel it is safe. And there isn't a lot of satisfaction. So negative perceptions about unit management and hospital management, they love working as colleagues, and they feel like the whole atmosphere could be improved. Next slide. So these were the clinical leadership. But this tool, leading a culture of safety, was at a higher level. Executive management, the board, the governing board of the hospitals. And again, there were these 5 dimensions about vision, valuing trust, respect, selecting and developing and engaging the board, leading and rewarding a just culture, and then establishing organizational behavior expectations. So again, we were very fascinated to hear that actually there are tools for measuring these. And in this particular instance, if you go to the next slide, you would see that after you've measured the tools by talking to people, there are recommended actions based on where you score them. So in terms of even establishing a vision, the question then becomes, is there clarity on the direction of the leadership of the hospital? Like, we want to reduce harm by 50%, or zero tolerance for medication-related harm, or no harm at all. And this is so clear that the orderly can talk about it, security can talk about it, the dispensing technician can talk about it, the nurse, the midwife, the pharmacist, the doctors, everybody is clear that in this hospital, this is what we are trying to do. Then in terms of the respect and the inclusion, transparency in sharing data. It was very striking to me when conversations started about sharing data, and a number of the doctors would be like, what are you trying to do? Are you trying to expose us? Are you trying to introduce us to lawsuits? What are you trying to do? But the data from other places where we work, Cincinnati Children's Hospital and other places, that when you're transparent, when you involve patients in the care process, when you engage them in quality and safety teams, actually the lawsuits go down because they trust and they know what it is that you were trying to do. They talked about engaging the board. That meant that we are being very intentional in moving away from an overemphasis on financial metrics. Are we making money? How much has been spent? Who has donated and all of that? And we are bringing the data on quality and safety to the attention of the board. And they are looking at it. How many people are being harmed from medication-related incidents? And what are we doing at the multiple levels? So getting the board to actually own the agenda and to assign resources to train people and to support people in the way that is required is what was needed. Then capacity building, training people at multiple levels. As you know, the trainings need to be appropriate for the various levels. So whether they are frontline staff, whether they are executive members, whether they are board members, there's an appropriate level of everybody to make sure that they are well equipped. So some may do medication reconciliation, some may do data and measurement, and so on and so forth. At the level of the board, they may look at the results of a survey such as this and what they can do to improve the attitudes in the hospital and their own attitudes. So yes, just culture, setting clear organizational behaviors where there are no 10 gods. The rules should not only apply to junior doctors. The rules should apply to the consultants and everybody. This is how we work in this hospital, and the tone is set very clearly. If not, then people think they can cut corners, and knowing that they would never be held accountable, and it's only the young doctors or the nurses that are perpetually being blamed for when things don't go right. The next one. So again, we did this, and yeah, the figures were pretty high, but in terms of compelling vision, people felt that there wasn't clarity about what the hospital was trying to achieve. And in the public sector hospitals, it was interesting because, these are people that don't even have to go and advertise for patients. They are already overwhelmed. So this issue about strategic plan development, quality and safety plan, vision, it didn't seem to matter a lot. Whereas the private hospitals felt like, yeah, we need to show, we want to go for accreditation, we want to do this, we want to do that, we need to have goals, we have to serve quality and safety teams. They felt that way. So it was very interesting to see the balance, of the various things. But the point is that it can be measured for your own facility, and then the recommended actions are there that you can follow. Next slide. Similar performance here that we can see. Again, not much by way of leadership for some of the hospitals. And then selecting and developing a board. By far, most of the boards were very focused on financial metrics, and the financial performance. Are we breaking even? Are we, is the bottom line great, succeeding, and so on and so forth. And it's not a question of how are the resources translating into better, safer care. And that was really the challenge that people had to address themselves to in terms of prioritization. That was also the challenge that was put to the board. On one board on which I served, the question was, all these things that you are doing, all these things that you are pushing, is it going to reduce cost or not? And it's like, well, in the beginning, it may drive up cost a bit, but when we have standardized, when we have trained, when there's a routine system of work, yes, the care will become more predictable, cost will go down. But in the beginning, it's seen as just a cost driver. It's not really seen as anything that is going to improve care until we get to the point where the quality of care has improved. Hospital is being commended and recommended, and patients are coming in and paying good rates. That touch the bottom line, and we feel proud because our metrics show it. Sometimes you face challenges at the very top because it's not that you're wasting money on these things. Next slide, please. So fortunately, this is the final one. And just a few reflections that the culture, the fundamentals, data, the training, and all of these things that we are speaking about, they are foundational. It will take time, but if we are deliberate about it and see it as something that we are doing on the long haul, not just a short-term project, it makes a difference. There are a lot of tools out there that we should look out for, whether it's in harm, whether it's in errors, whether it's in culture, whether it's in leadership, that can help us. We don't have to make it up. And three, the issues of culture, which are really foundational to medication safety and every other aspect of quality and safety, are driven by the leaders. Whether leaders have visibility on the hospital floor, the wards themselves, to see things for themselves, to listen to the challenges of the healthcare workers and proactively address them, whether they don't judge people harshly, but they address the root causes when things go wrong. They will set the tone for these things and nobody else. And meaningful patient involvement improves care, and therefore practical approaches are needed. We've done projects in which we've brought in patients, and I have been surprised by the strength of the opinions of the patients. You want to design referral forms, patients have opinions about it. You're talking about medications and you think it's a medical issue. No, patients have opinions about it. What you didn't say right, what you could have said, that would have helped them. But then again, it comes back to health professionals, because when you try to activate a demand for quality and safety and better quality care, some health professionals feel that you are instigating the public against them. And it's very very interesting for me to watch. But really, if we involve them, you want to design the emergency. Well, these are the designs. How can we do more of a human-centered design? How would you be comfortable? They give you perspectives that you never even thought of, So that kind of co-creation, that kind of sharing and working with each other is helpful, because the health professionals certainly don't know it all. And I think the last slide is just a summary of all of these things that we've talked about. You want to work in systems where no one is hesitant to voice a concern about a patient. We have skilled professionals that are well trained, not just in the core subject matter expertise, but also in the science of improvement and safety. And when concerns are raised, they are treated seriously, and people are not shut down for raising those concerns. In fact, they are encouraged to report near misses and errors, so that we can course correct as we go back, and then action is taken. Thank you for the opportunity.
Thank you so much, Dr. Soziteke, for such an illuminating lecture on this issue. It's really quite striking how important the culture is, and these issues that we call the fundamentals, having the data, listening, and making sure that healthcare professionals are actually trained. There's accountability. If people actually raise an issue, that people are willing, the institutions and their teams are willing to listen to that and take appropriate measures to address the issues. I have a very quick question. So we are going to open the floor to the audience. They can ask questions and we can have a conversation about this. But I'm very curious what you did in Ghana. What were some of the tools that you put in place in order to try to encourage people to overcome some of their resistance? Because one can imagine even just trying to gather the data to understand where the harm is occurring and where it is occurring. One could imagine that would have elicited resistance on the part of maybe the teams, the healthcare professionals. So how were you able to overcome those kinds of challenges in the hospitals that you looked at and get buy-in amongst the teams on the ground, the healthcare professional teams, the leadership, the management, and the board? Because it seems at all the different levels, there is a level of resistance, which is basically looking at different concerns, whether it's the bottom line, we want to maximize income, or we don't want to be blamed, or you're instigating the patients against us. Can you just talk a little bit about that?
Yeah, Yeah, I think there are a set of interventions all falling under the psychology of human behavior. And this is where you go into what motivates people, why people want to do the things they are doing. How can you create an attractive future? How can you say that if you did things differently, actually you get better results? It's money you're looking for, it's a good bottom line you're looking for. These are the things hindering you. If we were able to work on these, you would actually make the money ultimately. And then also creating some sort of a burning platform. So in the case of Clement's story, for example, this is Clement. How many other Clements are there in your facility? And do you even know? Are you not interested? And also the fact that if we ourselves fall sick as health professionals, it is these same hospitals, these same systems and processes that are good we're going to work on. So those are the things that you use to work on people's minds. The good thing is that nobody, no health worker is ever going to say that they do not support quality and safety. Everybody will say that it's a good thing, we support it. So then that becomes that, well, just supporting it in an intellectual way or supporting it by declaration is not enough. And then also showing them that there's a how to it, there's a structured approach to do it. And also in a project such as this, you also have to sell the fact that we have an opportunity to be innovative. So these are just 10 hospitals. There are thousands of hospitals all over Africa. So you have been carefully selected because you are an innovator hospital. And based on your lessons, you can become the next generation of teachers. So then they are inspired by that. Sometimes you will select hospitals that are already on a trajectory, they're on a journey. So one of the hospitals, for example, was already on a trajectory to get a loan facility from IFC World Bank. And that meant that your quality and safety performance needed to be on a certain track. Some of them were going to COSASA for accreditation. So this was just an opportunity to strengthen those systems, and we're very keen to be a part of it. Some of them were just motivated to be at the cutting edge, because there are some that are just excited by the newness of the work and want to be part of the change. And there are those that will come later. So in these types of projects, you need to be very careful in selecting people that want to be part of the new work, step into they are the innovator group. And similarly, we need to work with managers that have that mindset as well. Not people who are resistant or who tell you that there's nothing wrong with my system. My system is perfect. So I don't really need this project. Otherwise, you spend 6 months of the project trying to convince them. As opposed to people who say that, look, we've tried this, it didn't work. We are not happy with our system. What can we do? This project is a shot in the arm. So it's a combination of technical skills and soft skills to try and select the right group of people who want to do this.
Yeah, so more carrot. You have to think of, what the carrots look like and try to give a lot of that and maybe sell it to them in, from the perspective of what's in it for you. You get to lead or to be seen as a leader, or you can, it will enhance your career progression. Okay. Audience, you can come in with your questions. You can lift your hands and you can ask Dr. Sodzitete questions. Caleb Egwenu, you can take the floor with your questions. So please put on your camera and introduce yourself and your affiliation and ask your question, please, as briefly as you can.
Yeah, thank you very much. My camera is on. I'm Caleb Egwenu. From Nigeria, and I am a lung cancer patient advocate and research advocate with Move Against Cancer Africa, a cancer nonprofit. And thank you very much, Doctor, from Ghana. Just wanted to say you're doing great work in Ghana. But my question is, how do you, as like a patient advocate, how do you approach clinicians? Just giving you an example, I remember talking to a clinician, an oncologist, about shared decision making, and how it's good to educate the patients. And they were like, why would I want the patient educated so that I will be asked plenty questions? So I like it the way that the patient is not able to ask me, a lot of questions. So how do you think, that, we could navigate this in our setting? I don't know if the question is clear.
The question is very clear. So on this matter of the shared decision making, sometimes it's a question of there are the simple tools of questions that you can ask the patient as part of the service. So there's a way which you can introduce it in a softer way. So it's not a question of the patient coming to take your power. But if we get, first of all, management agreements, then it can be rolled down as part of the clinical guidance and protocol. So as you clock the patient, we would be happy for you to ask these 3 questions, and it is part of our standard treatment guidelines. That way, we try and move it away from the individual doctor's decision and preference and get it discussed, whether in a clinical meeting or as part of their protocol development, and then it works. The second one is also having a good understanding of what leaders respond to. So in that hospital, maybe it would be futile talking to that doctor one-on-one, but perhaps there's a medical director there that responds to a human interest story. So you could come and say that, you know what, Caleb was involved as a patient in the care in one way or the other, and this is how it improved, outcomes. And some may respond to that story. For example, depending on the leader that I'm working with and who responds to data, I may say that I've done a collaborative in which one group of hospitals had patients within their facilities and another group of hospitals did not. And in the matter of antenatal attendance, in the matter of the outcomes, in the matter of processes that were improved, those facilities that had patients saw more rapid improvements than the others. Some leaders will respond to that type of data. So understanding this and showcasing good examples are ways in which you can get their buy-in. I think for a lot of the professionals, they tend to feel threatened and not realize that it will actually make their work easier.
Thank you very much. Thank you.
Thank you, Dr. Sozitete. Ewalefo, hello. You can take the floor, introduce yourself, and ask your question. Go ahead. Ewalefo, do you hear us? Go ahead. You can ask your question.
Okay. Okay. Hello. Good evening, everyone. I am Ewalefo Nicholas Asibo, and I am a medical researcher. Thank you, Dr. Tete, for the exposition and everything you've spoken about. It really resonates with things that we see every day in the hospitals. Then my question is this. I am a Nigerian, so to say. In many African hospitals, supply chain vulnerabilities lead to infiltrations of counterfeit, expired, or improperly stored medicines. I would humbly like to know what practical steps can hospital pharmacists and clinicians take without relying on advanced laboratories to rapidly or swiftly identify and remove substandard products from patients' care areas? And how should they report these incidents when pharmacovigilance?
Okay. I think that the internet is a bit of a challenge at your end, but I get the gist of your question. It's about supply chain inefficiencies and substandard medication appearing at the front end. Often, when these medications appear at the front end, then it's almost too late, because then you are virtually almost at the point of dispensing them to the patients. So the preference is that we tackle these things head on, and I would have liked to see a situation where the regulatory authorities are able to even prevent medications from getting substandard medication from getting into the country. But often that is not the case because of the way the borders are porous, and also because of weak regulations and how people can just walk into any pharmacy and order their own drugs. But there's something that everybody can do. So you have Food and Drugs Authority, or I believe NAFDAC in Nigeria. They are then regulating the space in terms of giving people permissions to import certain medications. And in Africa, a number of those regulatory authorities are doing a pretty good job. They've gone up the ladder through various maturity levels at the level of WHO and are working on these. At the level of the frontline, where you talk about the pharmacists, basic things like checking for expiry dates, basic things like checking for the medications that have been supplied in terms of even packaging, where they have ways of detecting the counterfeit nature of them. There are also technological ways in which they've created some mobile applications where you can text the batch numbers and you would get an immediate response that tells you whether this is substandard or actually true. And also a big system initiative is the national health insurance schemes that are being rolled out in the various countries. And the move is to use that purchasing power to purchase high quality medication. So in areas, Ghana now is talking about insurance coverage of about 66% of the population. If we use the insurance funds to purchase high quality drugs, then that is what will be stocked and that is what will be dispensed to the patients. So unfortunately, it is not one solution, but a mix of interventions at multiple levels, including using technology to quickly ascertain whether the drug is fake or original. And that can be done at the level of the patient delivery.
That's great. Thank you, Dr. Sotitete. You know, to put it into context, we actually just had our last webinar was on the risk of substandard, falsified, how feasible it is. Because one of the things that this team did, they studied across 4 markets where they were looking at hospitals, private and public, and pharmacies as well, looking at medications there and measuring whether they were what they should be, you know, whether they're substandard or falsified. And they saw no difference from the formal channels, you know, and, you know, whether the medication was registered, which means it has gone through a rigorous process of evaluation by the regulator. Those products were not more likely to pass the quality test. It was quite uniform across the board. And one of the recommendations that they made, or that they think is going to be the solution, is that at the hospital, at the facility level, there's a need to actually start to use some kind of tool, perhaps one of the ones that you talk about, the technology tools that can allow you to detect whether a product is suspicious, but not to rely on that as the end in itself, but to actually go and do some basic test that allows you to see and to verify, because the copying and the counterfeiting, it's so convincing sometimes it's very difficult to be able to tell. So my question is, how feasible, I mean, what do you think about the idea of health facilities, hospitals actually having to institute this kind of policy where, especially let's say for high value medications like cancer, in Ghana, you're lucky you have the national health insurance, but not everybody across the continent is fortunate enough to have this system supporting patients. So you have patients paying a lot of money for medications that turn out to be substandard and maybe with no active ingredient at all, or they have too much and they cause harm. So if you could just comment on that, whether that's a feasible way to look at this, or whether there's a different way to look at it in terms of the interventions that we now need at the front line, at the hospital level, because it's clear these medicines are getting there. When you look at this data, it's actually quite, it's really quite incredible to see at what level they are actually able to overcome all of these barriers that exist to protect patients and still getting to the front line. And then I will take another question whilst you reflect on that. Musa, you can come in with your question, and then we take Funzo as well, and then we can get Dr. Soditete to respond. So Musa, put on your camera, introduce yourself, your affiliation, and ask your question.
So thank you very much for allowing me, and then Eid Mubarak to all of you. In the Gambia, we're observing the Eid today. And then also a good one to the presenter. It's timely as we are facing a lot of substandard and falsified medicinal products as a result of our porous borders. The Gambia, I am Musa from the Gambia. I am a principal regulatory officer at the Medicines Control Agency. So I just want to connect this important topic to the ADR, because looking at our systems in the Gambia, the reporting of ADR is very, very low. And then some of these ADRs could be as a result of such standards or also as a result of falsified, because most of these medicines could be coming into the country unregistered and unlicensed by licensed importers using the porous borders. And how would you use this topic to encourage more of ADR in order to detect substandards or falsified medicinal products? Thank you.
Okay. All right. That's great. So how would you use the systems that you have established and set up in your study and in your analysis within these 10 hospitals across 4 countries to encourage healthcare professionals to report more on adverse drug reactions? And it's true that it's not just in the Gambia that we are hearing that the levels of reporting of adverse drug events is extremely low. It really goes beyond that. We're hearing it from our community work in Tanzania. We're hearing the same in South Africa, in many countries, in fact, across the region. So this is a problem that is affecting many healthcare facilities. So that's the question. Funzo, can you ask your question, and then we'll ask Dr. Soditete to take the questions in a group.
I think Funzo had only reacted with the thumbs up.
Oh, okay. All right. Okay, over to you, Dr. Soditete. So the
Thank
first
you very
question.
much.
Yes.
Very thoughtful questions. The first one is talking about some hospital-based actions and whether those actions to be able to address the substandard medications are going to be enough or not. The question that I have is about sustainability and effectiveness of these isolated incidents. So you have a country, and if let's say 80% of the medications coming in are substandard, I mean, what can you really do as a district hospital on your own? You are overwhelmed. And when you ask the patient to not even take what you are dispensing in the hospital, but to go to the next pharmacy or community pharmaceutical shop or a licensed chemical seller, the likelihood is that it's also going to be fake at that level, which is why I would be more in favor of system level solutions. And I think that sometimes as a health system, we don't use the purchasing power of the health system enough. You are spending millions and billions buying medications. Why are you not being more selective as to who you're buying from? That's really the question that we have, especially given the regulatory weaknesses. If we did that, at least we can be sure that within the public system, which is delivering in some instances over 70% or 80% of the care, at least people can be assured of the quality of the medications that they are receiving. Then there's this mobile app that I'm talking about. Pedigree is, I believe, the organization that rolled it out. Again, that is a way in which you can connect directly to the front line, where if they check, it will be quickly ascertained that it's of a substandard nature. And mind you, those people selling substandard medication are all about the money. They are driven by the profit motive. So if they understand that patients will check before buying even from them or before taking these medications, there will be no business, and that would automatically kill whatever it is that they are doing. And that, for me, is linked directly to the ADR conversation. It's about health education, and sometimes we do not do enough of that. It's about giving people appropriate information. When we give the example that I cited, for example, meant that we did not even tell the patient about the route of administration of the suppository, let alone talk about the possible side effects that they would be able to see and whatever adverse reactions may emanate when they take it, and for them to even report. But this matter needs to be routinely discussed with every dispensing activity. So we are perhaps failing in raising the consciousness and the educational level of the patients and bringing the awareness to what to expect when they are given these medications. Also, even public education, on radio, on TV, targeted, to let people understand that this is what you might expect, and let them know that they are partners in this whole journey. And if they report, it only makes things better. So being a bit more activist, as opposed to just sitting down, being relaxed, because the patients will come to us anyway. Because there's a thriving industry out there, as much as I hate to admit it, that is really, trafficking in these substandard medications and making tons of money. And also, if you look at the regulatory landscape in Africa, it's only 9 countries that are at maturity level 3 for WHO. And if you look at the sheer amount of work that has to be done to be able to contain these, it's not easy for them. So this is why I would advocate for us to establishing control where we have control, and to use our money to intervene positively, and then to activate reporting systems when things go wrong and to address them accordingly. So those would be my reflections.
No, I really like the point you make about where we are failing the most, raising the consciousness and awareness, in particular of patients, so that they become a partner in this, and how you are linking the adverse drug reporting, that signal detection with health education, and that pair of things being actually quite critical to being able to take away their business from the counterfeiters, who are preying on the fact that people perhaps are not aware, so they may not ask questions or be suspicious about what they might be taking. And I think it links to a bigger point that is often made about one of the main solutions that people talk about. What is the solution to tackling the high prevalence of substandard, of counterfeited medicines that are deliberately targeting African markets? Local production, right? If we have products being locally made, there's just a level of control that regulators can have that is difficult for them to have when products are coming abroad. And often the counter argument is that, yes, but people don't really like products that are locally made. And I saw an interesting statistic today that was a survey that was done in Ghana about how many people actually, they did a survey, and I think more than 70% of the people surveyed were quite open to taking medications that are locally made. So I think there are a lot of assumptions and things that we say that we need to really go out there and get the data and really understand this. And of course, countries can use their purchasing power to make sure that they are able to really make sure what's coming in is safe for patients. So I just wanted to add to your point. I thought that was a really, really great point. What was the other question? The other question.
The other question had to do with the adverse drug
Oh, yes.
reactions. The last one was somebody who raised their hand or was given a thumbs up, not really a question.
Yes. But I actually wanted Musa. We often have, and other regulators that might be here. We often have quite a lot of regulators in the room. But Musa, are you raising your hand again? Because I was actually going to bounce this back to you. The point that you made.
You can go ahead.
Yes. You talked about the low levels of reporting and how you can use this. I was curious if you could maybe just comment for us how the Gambia has looked at this, because of course we've all seen the big tragedy with the cough syrup in the Gambia, which really broke the hearts of many parents across the continent. How have you actually in the Gambia, what steps have you taken from that place to actually encourage adverse drug reactions? Because if I understand correctly, one of the challenges in that particular case was actually the amount of time it took from the cluster of these young children coming in the same area with kidney failure and all kinds of things to actually confirming that it was actually related to a medical product that all these kids had taken in common. So how has things changed in the Gambia? I don't know if you're able to speak to that, but I'm very curious to hear more about that.
So thank you very much for that important follow-up. Regarding the issue of the AKI, I mean, I am privileged to be part of the respondent. At the time, I am an epidemiologist by training, and this was shortly when I just completed my intermediate field epidemiology training that this came up. As a matter of fact, it was myself and then the program manager for the epidemiology and disease control unit of the ministry who first responded to the call from the Edward Francis Small Teaching Hospital when one Nigerian professor, Professor Vivian, detected some unusual occurrence among children under 5 at the pediatric ward. So we actually, as epidemiologists at that time, uh, we were focused on what could have been the cause, what were the risk factors. Well, our focus was on the water that they were consuming. So we took samples from waters at various areas that were affected from the upcountry coming down to the urban area. We were not thinking at that time it could be as a result of the medication that we are used. However, using our epidemiological skill, we actually advise that all children or every child that is brought to the teaching hospital should be carry along with the medication that they were using. And it was as a result of that, and then also from the experience that Prof. Vivian had that occurred in Nigeria some time ago. So it was associated to the medications that they were using. I will not want to go deep into it as some things change when I also went and studied pharmacy and now working as a regulator. But also, the matter is before the High Court, and I think, in fact, it's about judgment time now because all the witnesses came, and then they are about to do the judgment now. So I don't want to contempt anything, but then I know you will hear soon. But then interesting revelations came, and then I can tell you that it was defended in court that some of the death could have been not associated with the cough syrup that they use, but could have been associated with something else. But it's up to the judge to determine that. But scientifically, some people stood and then defended that it could be as a result of something that is different from the cough syrup that was used. So coming down to the best practice that we use, it was after the advent of this COVID-19, not COVID-19, the AKI that we strengthened. The laws were there since 2014. However, they were not strengthened as a result of one, finances or logistics, and of course the human resources that was available at the Medicines Control Agency at that time. So it was after this thing that it was strengthened, and now we are boasting. It was after that that most of us were actually employed, and then to the Directorate of Operations. So just to give you a bit background about myself, I am a senior military officer. I am a major, and actually I studied public and environmental health. At masters, I did my health promotions and development. I'm a health promotion expert, and also I was further trained on field epidemiology, both frontline and intermediate. So it was during this period that they advertised this position, the position of a regulatory officer for operations, and then I applied and I was taken on secondment. So you can see the transformation that the agency is having, and then we also appointed at the time one focal person for the substandard, and when I came in, I was appointed as the second to the focal point. And then we also had some grants that we are implementing, though not my Directorate of Operations, but then the Directorate of Pharmacovigilance and Clinical Trial. So in the Gambia, the pharmacovigilance is annexed to the clinical trial, not under the Directorate of Operations. Under the Directorate of Operations, you have the post-market surveillance. So we won a grant that we are sensitizing the mass on adverse drug reaction and how to report it. Also, we are sensitizing health practitioners. However, the gap that I observe as a researcher, as an epidemiologist, is that we leaving a very important stakeholder in this, and that is the pharmaceutical outlets, the premises. Many a times people will rely on these drugstores or pharmacies. They buy these medications from them. And a pharmaceutical product should be able to do what? When you consume it, it should have a therapeutic effect. For example, if you use a paracetamol or the ibuprofen that is meant to reduce fever or to relieve pain, and then you're seeing people coming out from you, what is that? It's an ADR. How do you report these things? Do you go back to the premises that you bought it from? Are we educating people on this? Who are the stakeholders? Is those people actually selling this at those drugstores? So to me, it is important that they come on board and then to be sensitized. So it is for this reason that this time around, we have included these things and then want to do more and a rigorous sensitization, both in public and then in healthcare workers and the stakeholders that are involved in the pharmaceutical supply chain. I'll stop at that for now.
Well, thank you for that very, very extensive explanation. And I guess, like Dr. Sodzitete said, it's about learning, right? What you learn from the situation and how you take corrective measures. And it's great to hear that you are taking quite a number of steps in the Gambia, and perhaps we should invite you here to talk to us about that, some of the, the learnings and what others can learn from your experience that could also be helpful for others in different contexts. Dr. Sodzitete, I think, what would be really interesting to hear from you is how this amazing study that you have done, because it has so many lessons, I think, in terms of how we can implement solutions to prevent severe preventable harm amongst patients and, in the clinical settings. I think if you could maybe just explain to us how could this solution be scaled up, beyond the 10 hospitals that you have studied in 4 countries? How would one go about scaling this up, trying to get more buy-in, and in particular with the focus on the public health sector, which you explained that generally they're inundated by having too many patients. They are overwhelmed anyway, so there is no motivation to do better because it's really not going to affect the bottom line. They're publicly funded and so forth. So how would you go about scaling up a solution like this, in particular in the public sector where it's probably needed the most? I'm sure this is happening across, right, public and private, but the biggest, I guess, the problem, the magnitude of it is even bigger in the public sector.
Very powerful question as usual, Lenius. So there's a whole methodology to scale up that we sometimes would work with, and you do need to be thinking of that at the beginning as you design the initiative. What a number of people do is that when they are ending, then suddenly they wake up and realize that actually we have true owners of the health system, and that you have finished your project and you're leaving and you're not going to be there. So it's always important to co-design and to co-create with the owners of the health system, which is some of the things that we did. To build well, at multiple levels, that it's not just a short-term initiative, but it's an initiative that we are going to uptake, and then drive forward, especially with demonstrable results. The third bit has to do with the site selection. You need to be able to select sites that mirror the entirety of the health system. At the end of the day, what you're doing is just a prototype. And you want to be able to get a variety of the experiences, which is why I talked about faith-based, I talked about private, I talked about public, so that whatever you develop in the end as key lessons and guidelines are truly practically applicable to their concrete realities every day. So that's very important. What happens, and it was on one of my slides where I showed you the design framework of the collaborative learning approach. At the end of the day, you have what we call a change package. That change package is your evidence-based articulation of what it actually took to do such an initiative. So then people will talk about the what. That becomes the what. If you want to reduce medication-related harm in facilities, what do you do at the leadership level? What do you do at the level of middle management? What do you do at the front line? When you talk of capacity building, how do you build the capacity in a seamless way? How do you leverage the training institutions that are there? How do you infuse it into their curriculum so that the new doctor, the new nurse, the new midwife, the new pharmacist that is coming out knows about medication reconciliation already? Doesn't have to be taught afresh. Knows about how to use the global trigger tool already as part of their training. Whilst we run in-service courses, we also integrate it into pre-service education. So this is the way to think about it for both short-term and long-term gains. And then also data. Data is a big one. And you will see that as part of this prototype, you would have gone through an elaborate process, testing tools, testing templates, and all of that. I think once you are done with your initiative, which will run from anywhere between 18 months to 24 months, you need to standardize these tools. Make them very simple and easy to use, because you may not be able to bring people out and train them in batches until they've trained everybody. So you make it easy to use, almost intuitive, commonsensical, in the way in which it can be used. And then people use it without even thinking twice about whether this was something that was developed by this software or that software, but it's so easy. The way people can pick up mobile phones and use them, this is how simple you want to make your change package, that people can actually do it without a whole lot of training in the intense way in which you had to engage in the design phase. Then, of course, there are policy level issues. So Are there new guidelines? Are there new reporting frameworks? Are there requirements for feedback and things in the system? Are there requirements that you publish certain quality and patient safety performance reports every year or every 6 months? Try and systematize it. This way, you try and lock it in. That's the way I would look at it. And then, of course, for those that continue to perform in ways that are not in line with professional standards, they can be handled by the regulatory authorities, medical and dental council, and the rest.
Thank you, Dr. Sodzitete. I think we have come to the end of the webinar, and I mean, for me, this was a really insightful case study, which really tells us that a lot of the improvements that are needed to prevent harm at the front line in clinical care is a lot to do about people, about culture, how people interact, healthcare professionals interact amongst themselves, how they interact with the boards, the management, how they're interacting with their lower levels, and how people at the front line, the healthcare professionals, are interacting with patients, the willingness to listen, to hear the perspective of the patient. And you gave that very powerful example of that gentleman who, a nurse was insisting on giving him medication at 5 a.m. And he said, I don't take medication at 5 a.m. And it turns out it was for somebody else. It could have, obviously caused him harm if he had stood down. So it really shows the importance of listening, of communication, of those interactions, and of being respectful and listening to patient voices as well, because they are a very, very important stakeholder that if we don't listen to them, if we leave them out, we are more likely to do harm than good when we are trying to take care of patients. Funzo, you now have your question. Okay, we'll allow you very quickly because I think our speaker needs to go. We are way over time already. Please go ahead. We cannot hear anything you're saying, so I think we are going to close the meeting here. Dr. Sodzitete, thank you so much for a really illuminating conversation, for your presentation, and of course the recommendations that you make. And for me, one of the most powerful recommendations that you made is how countries and buyers of medicines in particular, health insurance schemes can use their purchasing power to really make sure that they use it to make sure nothing that is from the gray market is entering the formal supply chain. It's one of many powerful recommendations that you have made, and we will be sharing this with others. The recording will be available and we'll share it with you as well. And we are very concerned about patient safety, and we are trying to figure out how and what we can do to improve this situation. And the front lines are, people, healthcare professionals on the front lines are one of the major stakeholders that you also mentioned as being particularly central to bringing about change and being better able to have protections for patients, to provide safer care. So thank you so much on behalf of our team here at Medicines for Africa and our youth. We are working with a lot of young people in different countries, including in Ghana, in fact. And yes, and so we are very grateful for these lessons, for you sharing with us the things you have learned, because it's really given us many ideas of how we can also intervene from our perspective as a social enterprise, working more in communities, and what we should be doing in our communities to sensitize people to become agents of change in their own care to make it safer. So thank you so much, sir, for this amazing presentation tonight.
Thank you for having me. I've had a good time, and I've also learned a lot. I look forward to connecting with you at some later date.
Let's do that. Thank you.